Health Podcast, the podcast that brings you a complete view of healthcare, exercise as medicine, and much more.
We're your hosts, Helen O'Leary and Reece, both physiotherapists at Complete Physio and Pilates in London.
This is episode 2, the second part of our sit down with Complete Physio Director Chris Myers, where he delves into one of his areas of expertise and passion, Diagnostic Ultrasound.
One of the clinical hats that Chris wears is that of an MSK sonographer, meaning he's also able to use Diagnostic Ultrasound to diagnose musculoskeletal pathologies, which can help guide your treatment.
There's definitely some clinical gems in this one for the clinicians and patients alike. We hope you get a lot out of it. Here for part 2 of our chat with Complete Physio Clinical Director Chris Myers. For those of you who haven't heard, podcast 1 with Chris was a good conversation between himself and Helen, really about the origins of Complete and where they started and how the companies work together. So if you want to skip back and have a look at those, it's a really good listen. So I certainly learnt a lot, and I've worked for Complete for 18 months, so it's finally nice to know these things. Section 2 here with Chris, we're going to focus on ultrasound and sonography. For those of you that don't know, Chris is one of the leading certainly one of the leading physiotherapists in sonography, as his head's growing here, certainly in the UK, and he does teach all around the world as well. So he's extremely qualified to be talking about ultrasound and particularly, I guess, where that fits in the patient journey to getting people back to healthy and happy and doing the things that they're wanting to do. So Chris, I guess just to start off, how did you end up as a sonographer? Because obviously not all physios do it. It's not part of our basic training. So where did that start? Where did the interest spark off, and how did you end up qualified?
Yeah, so I can remember the day it happened, actually. It's like when your children, or if you have children, which I don't. But anyway, so it must be about 12 years ago. I was working as an extended scope physiotherapist in the NHS with Dave Baker, who I run Complete Physio with. And we were carrying out unguided steroid injections.
Yep, which isn't uncommon.
Yeah, which is it still goes on. Yeah. And certainly back then it was the norm. So that's basically when you carry out a steroid injection for something like frozen shoulder or arthritis, and you don't use any form of imaging to guide the needle. So and there was certainly evidence coming out at that point that maybe we weren't injecting exactly what we thought we were injecting. Yeah. The way to get over that is obviously to do an accurate injection, carrying it out under either ultrasound guidance, or some people do it under fluoroscopy, which is a type of X-ray, or is an X-ray. But we decided that it would be really good to start offering ultrasound guided injections in the NHS. We were very well supported by our manager, and a few of us went off, and once we brought a machine in the clinic, we went off and did what's called a postgraduate certificate. So a postgraduate certificate is what you do to become a musculoskeletal sonographer, and that's somebody that uses diagnostic ultrasound for the diagnosis of lots of different sort of soft tissue and nerve and joint problems. Through that process, you have to carry out 250 scans. You have to scan with a supervisor every week. So it's really intensive training. It's basically retraining in somebody else's job. But as a physio, it is, for me, it's just the sort of natural extension of my assessment. So I'll carry out a normal assessment like a physio would do, and then I would extend that and carry out a diagnostic ultrasound scan. Yeah. So that really helps me to confirm my diagnosis, and that's really important before you even think about an injection, is to make sure you've got a confirmed diagnosis and it's the right thing to do at the right time. But obviously from that, you can then carry out an ultrasound guided injection. So what you end up with is what we call at Complete, is essentially that one-stop clinic. Yeah. Where a patient comes in, you do a full history, you do a full examination, but there and then in the clinic room you carry out a diagnostic ultrasound scan, and obviously for somebody that's booked in for an injection, or where it's appropriate for an injection, you can carry out an ultrasound guided injection. So that really is a one-stop clinic, and certainly at the moment on the NHS that could be a 6 to 12 month pathway, whereas we can do it in 30 to 45 minutes. Yeah, Australian. So it's a pretty awesome service. It's quite a unique service. It's an affordable service, and it's something that's very useful, and something that we've integrated now into Complete now that we've left the NHS. Yeah. And yeah, it's as I say, it's a unique service, but I think it's really great to have that position within a physiotherapy clinic.
Yeah, you touch on it there. I'll just get you to expand on it a little bit. Obviously, people coming in for an ultrasound scan, I think it's important that the knowledge is there that they're going to have a full assessment first. It's not come in, I have a sore I have a sore shoulder or a sore hip or whatever it is, lie down on the bed, get a scan. It's, I'm going to assess you as any physio should, and then this is what I think it is. I'm now going to ultrasound you to confirm that.
Yeah.
That's
really important. And the classic saying is treat the man, not the scan. Treat the woman, not the scan. Sort of works too.
And that's not just for ultrasound scans.
No. So
MRI, CTs, anything.
And I think there's certain groups of clinicians that sometimes look at the scan before they actually assess the patient. We would always assess the patient first, and then we will use and when you carry out an assessment, whether it's a physiotherapist who scans or not, you're already forming your hypothesis and your diagnosis of what you think is going on. And you might in your head come up with 4 or 5 different things. So for example, for a shoulder, it could be, is this a bursitis? Is this a frozen shoulder? Is this a tendon tear? Now, clinical assessment can differentiate that. So not everybody needs a scan, but if you want a little bit more information, or you want to confirm the diagnosis, for example, if something's not getting better, or if you're considering an injection, then an ultrasound scan allows you to do that. So it just helps you to gain what we say is just another layer of information to the clinical assessment.
So even if you're quite certain of your diagnosis through clinical findings, would you still do a scan?
So there's certain conditions where you don't need imaging. So for example, a frozen shoulder is a clinical assessment. So that's something that a physiotherapist can assess, and that you don't need imaging to confirm that diagnosis. I'll get a few examples of where I would want imaging relatively quickly in the patient pathway is, for example, if there's been trauma. So if somebody's fallen over, that's a classic, fallen over whilst running, fallen onto their arm, and they've sought an assessment by one of our physios, they're very limited in their range of movement, they've clearly had trauma and they're not improving. That would be somebody where I'd want a bit more information as quickly as possible to ensure that that patient gets the right diagnosis and is therefore not wasting their time with their management plan. A significant, I think we have about 6 of our physios now that do diagnostic ultrasound, and that's out of sort of 15-20 physios. But what we have is a situation where if somebody needs a scan, then they can speak to one of the physios that carries out the scan. We don't charge specifically for the scan. We just think it's really important and actually probably the main focus, if you ask me what the main focus of our clinical assessment, or not just our clinical assessment but our clinic, is to get the right diagnosis as quick as possible and not waste people's time, and ensure that they're getting the appropriate treatment.
Yeah, definitely. And I know from my experience, it's great to be in the clinic with you, because you can just, this is what I've found, this is what I'm thinking. Chris, can you quickly have a look at it? And confirms it most of the time. Or might lead you down a different pathway. So either it's confirm to the patient that we're on track and we know what's going on, or we've picked something up that we otherwise might not have.
And we do have that. You have situations where you do find things on ultrasound that you did not expect from your clinical assessment. And that's what's great about having ultrasound on site and in clinic, is that we can get that information. And I think the key thing is if you've had trauma, so if you've had a specific incident, I think it's good to get some imaging. Diagnostic ultrasound is very good for muscles and tendons, particularly for muscles and tendons, to look for any structural change. But also if people aren't improving, or if they come to the clinic and they've had 4 different physios from different clinics, or they've seen a sports doctor or an orthopedic surgeon, maybe they haven't had imaging for a while, or they haven't had imaging at all, then it's quite good to get some baseline imaging to see whether or not there is something, and that patient is that person where actually this hasn't been picked up, and it will potentially change the patient pathway.
It does happen, doesn't it?
Yeah.
So you speak about baseline imaging. So does that mean you would use it as a reassessment tool as well after a period of rehab, or how does it fit?
It depends on. That's a good question. It depends on the condition. So because I carry out quite a few ultrasound guided injections, there are some conditions where I may rescan to see if they're improving. If they've had a rotator cuff tear, then I may rescan to see if there's some primary healing taking place. But as I said at the beginning, we always base, if a patient feels better, they're better. Do you know what I mean?
Yep.
Whatever the ultrasound scan. So we always hang our hat on our clinical assessment on what the patient is telling us, and the ultrasound is there to support it, but we would always focus on what the patient is saying.
And I think that's key, because you could image 100 people and they'll all show abnormal kind of things within joints or muscles or something, but actually there's a very large degree of normal, so most people won't have a quote normal.
And there's absolutely, and there's lots of red herrings, as I call them. So basically, a patient will walk into clinic and they say, I've got a rotator cuff tear, but it's not, unless they've had trauma. That rotator cuff tear, particularly if they're over the age of 50 or 60, could be normal age-related change. And we all know, everybody at this table is over 30. I'm the youngest by far. We know that people over, even elite athletes that are 21, they have imaging changes and structural change. And the key is to relate that structural change to the clinical assessment, and that structural change may be irrelevant to that patient's presentation. And that's why imaging is very effective in the hands of the person carrying out the clinical assessment. If you can do imaging and the clinical assessment in the same room at the same time, you are more, in my opinion, you're more likely to find the most relevant findings to that patient's condition.
As long as it matches up. Because just as a bit of a side note, I guess, the classic one is the MRI of the lower back. That's the classic findings, where basically every decade you go up, it's 10% more changes.
So from the age of sort of late teens, early 20s, you will get degenerative change in your spine.
And I'm sure we've seen
which of course is not degenerative change, it's just normal age-related change.
And the biggest factor for that is genetics. So you can't even change it. There's lifestyle factors that can kind of come with that, but your genetics are your unequivocal reason for
thanks mum and dad. And we've all seen it. The classic is the patient walks in and you say to them, how can I help you, what can I help you with? Scan. And you're like, okay, but we'll look at that in a second. Let's assess it, and then they've got right-sided low back pain, but they've got a left-sided disc bulge.
So it happens a lot. It happens a lot, and that's where you've got to put everything together. That's why I think physios, particularly the guys that we have, are in a great position to carry out that full clinical assessment. And I always say to people when they, when they've been elsewhere, it's like, well, what did they get you to do? What did they look at? And that sort of thing. And that can generally give you an idea of how much time they've spent actually doing a thorough clinical assessment. And that's really important. Most of us will actually treat a patient before we even look at the scan results anyway, and that's why we always do an ultrasound scan at the end of the assessment, because you don't want that scan biasing your clinical assessment.
100%. Absolutely. It's one thing I've really found since working with you, and obviously having that ability to give people scans under the same roof. It's all, I don't have to send them off to a diagnostic imaging place or anything like that. I've found that it's quite powerful for some buy-in as well. Like, what are your thoughts around that in regards to, I guess if you can get that 100%, there it is on the scan after your clinical assessment, of course. Like, do you feel that that's more likely that people are then going to see out their course of treatment?
I think absolutely. At the end of the day, the first stage of any treatment is getting the right diagnosis. And if we're all very skilled practitioners and we can feel things and we can see things and we can move things, but actually, to actually then take the next layer and look underneath the skin, you're going to have that. Your patient is going to have the confidence. Not only do you think this is what's going on, actually this is what's going on, because this is what we can see. It's black and white, literally, on an ultrasound scan, and it really helps with patient buy-in. And the other point I would make, and it links into what you said about imaging, is from a patient point of view, we know that imaging can mean different things. The same imaging result can mean different things in different patients, because it depends how they assess clinically and what their function levels are and what their pain. We know two people can have exactly the same scan. One can be in 10 out of 10 pain, and one can have 0 pain and be an elite footballer. We know that. There's enough evidence now to support that. So how you present. So it's not just about the actual image itself, it's about how you present those imaging findings to the patient. And actually the worst thing you can do with imaging, and we know imaging does this, and this is why we have to be careful with who gets imaging, is it can promote a lot of fear in patients.
Yeah.
And one of the biggest things I try and pick up in clinical assessment is that fear factor. So if somebody says, well, I'm not running, I don't want them to go because I've got a disc prolapse. I want to know why they're not running. Well, why aren't you running? Well, I saw an orthopaedic surgeon 10 years ago, and he said I shouldn't run with a disc prolapse. Well, if everybody in the world didn't run with a disc prolapse in this country, let's work it out. If there's 60 million people, we know roughly 40% of people have something wrong on their spine. So 40% of 60. Reece, what's that?
A lot.
Quite a lot. 24 million.
Yeah, so really? Yeah. So roughly 24 million people shouldn't run.
Excluded from running.
So say that, the couch to 5K.
And that's only people who have said that they've got something wrong.
So we should never make decisions on the scan. Now, how you present the imaging findings and how you communicate that with the patient is probably the most important thing.
Yeah, for sure.
So if I say to somebody, you've got a rotator cuff tear on the right, but actually I'm scanning your left, you've got exactly the same, then those imaging findings are probably less relevant to that painful right shoulder.
Yeah.
So how you present it is either going to inflict fear for the rest of their life, which is my pet hate, or it's going to actually encourage them to exercise because you're making their imaging, if you like, more normal.
Yes.
And that's really important. And physios are really, and I think we're particularly good at that, because we will always start with that clinical assessment. And it's that classic thing of you shouldn't run, you're going to wear your knees out. Well, actually there's more evidence that running will improve the strength and stability of your knee.
It's actually protective.
And this is this fear thing is the biggest risk factor of chronic pain. So if anybody that's got chronic pain out there and they're sitting there going, I'm scared of doing this, then that's the patient that we enjoy treating because we think we can make a big difference with.
Yeah, and I think the big thing for me with those people, it's focus on what you can do, not what you can't.
Exactly.
And you can sort of almost see things come over people's face when you say that to them. Okay, so I know you can't do these things, or you've told me you can't do those things. What can you do? Let's focus on that. And they're like, oh, actually, I can do quite a few things. So
But when you say why can't you do it, they can't actually answer it.
Yeah.
But they've been told they shouldn't do it, or they think they shouldn't do it, and that comes down to pain.
Yeah, and this is where your pain questionnaires and things come in, because actually some people don't realise that that's what they're saying. So by giving a kind of subjective questionnaire which asks a lot of those things, and then they sit there at the end and go, oh, I didn't realise that that's where I was at. That's another kind of good baseline measure which can form part of your clinical diagnosis if you're worried that someone's kind of involved in that fear.
And so I think, just going back to the ultrasound side of it, I think it helps to empower the patient, but at the sometime we see patients where actually they do need to back off a little bit. Not often. It's very rare we will tell somebody to stop running, or but for example, if I scan an Achilles and I see a tear, or I see a big bursitis, which is inflammation of the sort of sac that's in front of the Achilles, then I may need to just back them off running for a couple of weeks, or modify their running at least. So it can really help. You can use that imaging not only to get the right diagnosis, but to help structure your rehab, basically.
So will you kind of use the ultrasound image then to kind of guide, whether it be, you take the rehab or somebody else takes the rehab like Reece, will you use that imaging to then determine load or determine where they should be starting at? Yeah,
so in terms of tendons, I think the imaging's going to, the main priority for the imaging is it's going to give you the diagnosis. And from that, you'll be able to work out whether this needs a heavy load program, or it needs an injection, or it needs shockwave therapy. So, and it's not that black and white, but it certainly, with experience, you get an idea of what somebody is going to benefit from at what stage. So exactly. If they need more of a rehab load specific a rehab, then I might refer them off to, say, Reece, or somebody that does lots and lots of rehab, or into the Pilates studio if we know they need to work on their more proximal control, so something a bit higher up. So it can help with that. But certainly the priority is that it's giving you that diagnosis there and then, and particularly for those patients that have had trauma, so that they've felt something go, or those patients that aren't improving. I think it's really important to get some imaging.
So those are the kind of patients that it works really well for. So what can't you scan, or what doesn't it work well for?
The spine. So diagnostic ultrasound is excellent at seeing things and structures that don't have a bone in the way, because as soon as ultrasound, which is just sound waves, hits a bone, it reflects back. So it's like bouncing it into a mirror. You can't see behind a mirror. So as long as there's no bone in the way. So shoulders, absolutely brilliant for, in my opinion, gives you more information than MRI for a lot of these rotator cuff tears, etc. Elbows, very good. Wrists, pretty good for, certainly for certain tendon conditions. Hips, pretty good for. Proximal hamstring, which is the tendon at the top of where it attaches onto the bony bit of your bum that you sit on. It's not bad for that. It's probably not as good as MRI. Knees, you can get some useful information. Then obviously any muscle tears or tendon problems, it's really, really good for. So for most of the things that come into our clinic, unless it's a spine, diagnostic ultrasound definitely has a role.
So sort of anything around the limbs.
Yeah, and what's great about ultrasound is, first of all, you can scan the asymptomatic side, so you can actually do a comparison from right to left, which MRI, well, particularly privately, that will cost you another 300 quid if you want to scan the asymptomatic side, which they probably wouldn't do anyway. So you can compare side to side really quickly. And also it's dynamic, so you know, unlike MRI, you're lying down on your back and having a scan done. Ultrasound, you can move, you know, most people come in because when they move something, for example their arm, they get pain, so you can use ultrasound dynamically to assess the joint or the tendon or the ligament whilst they're moving the area that's painful using their aggravating factor, and that can give you really useful information.
It's a bit of an extension on the physio's old favourite of "does that hurt?"
Yeah.
Instead of your thumb, it's an ultrasound probe. You can give that dynamic information. Chris, you do a fair bit of teaching. Both here in the UK and internationally. If anyone's interested, where do they go?
Well, they can go. Well, I run a company called Smug with a
so fitting for you. So fitting.
Which is called the Sports Medicine Ultrasound Group. And yeah, if you Google that, it will come up. But what we're finding is that it's not just physios that use ultrasound. Anybody where you've been in and you've had a clinical assessment, ultrasound can be useful. So orthopedic surgeons are learning how to do it. Podiatrists are learning how to do it, osteopaths are learning how to do it, obviously sports doctors are learning how to do it, and that's because we appreciate that there is an element of guesswork to our clinical assessment. Educated guesswork and experienced guesswork, but unless you're actually looking underneath the skin, there is going to be an element of guesswork to it. So lots of people are very interested in it.
It's quite amazing. So I refer quite a few people off to you and sit in generally on the ultrasound scans, and it's actually been, for me, I've found a really nice way to retouch on my anatomy.
Yes.
Because obviously loved anatomy at uni, but don't really retouch it that much once you're qualified and working. So the ability to look at the muscles, and you can see muscle compartments so clearly on there. You know, we were scanning a hamstring just last night, just yesterday, and you know, you can see the tendinosis, membranosis, you can see it all there. It's actually amazing just to rehash a little bit of that and get you thinking.
And the anatomy is different to the books.
Oh, massively.
So we always say that, you know, you either think about anatomy, so radiologists and that will think about anatomy on an MRI scan and they'll compare it to an ultrasound, whereas physios, we think about it really from an anatomy book that isn't always the most accurate representation of it. And I always think that at undergraduate level ultrasound should be used to teach anatomy, and you really then get that appreciation of what things actually look like.
The old, is it Netta
or Grays?
Fantastic books. They were good. And then again, you touched early on, Chris, about injections. And obviously the heavy link between ultrasound and injections. So how have you seen that develop yourself, not just with your practice, but overall in the world of physiotherapy?
Well, obviously, you know, physios in this country have a wide scope of practice. So physios have been able to inject in this country for probably 20 years now, and probably more. And obviously sports doctors, orthopedic surgeons, lots of people do these injections, and there is certainly in private practice in London, it's almost frowned upon really now if you were to do, or in my opinion, not frowned upon, but certainly most people should be having an ultrasound guided injection.
There's enough options available that it's not a rare thing anymore, is there? You can find people to do it guided.
Now obviously in the end, you know, this is private practice in London. I think, you know, particularly with health insurance, most injections now, to be honest, will always be done guided. In the NHS, Lots of injections are done unguided. Where I worked in the NHS, we did them unguided, and then when we started doing ultrasound guided injections, the GPs were still doing unguided, and we said that's fine, because a lot of unguided injections will still work.
Yep.
And the research shows that in some cases guided injections will give you a better result. Anecdotally, I find quite often that it does give me a better result from when people have had previous unguided injections that haven't worked. And we used to say, well, if they've had an unguided, you didn't get the desired response and you're confident of your diagnosis, then consider getting a guided injection done. So I'm not saying every injection should be unguided. I can assure you every injection at Complete is done guided.
Yep.
And I do anecdotally feel that that's the way that we should be doing it. But I think what's important is it's not a debate between guided and unguided, because you've got to remember that ultrasound starts with a diagnosis. And getting the right diagnosis is essential to doing the right treatment, as I said. And if a steroid injection or another type of injection is part of that, then you've got to confirm your diagnosis first before you do your guided injection, and ultrasound allows you to do that whole sort of one-stop clinic that we talked about earlier.
How's that gives you that real confidence, doesn't it?
Yeah, it does.
Putting it in.
And also, the other thing to mention is the question is, how does the injections fit into a physiotherapy practice? Well, I just think it fits perfectly into a physiotherapy practice, because physiotherapists always wanting to. We know that most things need moving. We know most things need strengthening. But if pain is your limiting factor, so if pain is your limiting factor for rehabilitation, and you've tried lots of different options and you're not getting somewhere, then as physios we can be quite limited.
Yeah.
But actually, if it's appropriate via the correct diagnosis to have a guided injection, you can settle the inflammation and the pain down, and that gives you that window of opportunity that in our clinic we see as the deal breaker, really, between whether people get better or not, and whether they engage in their rehab, and in lots of cases avoid surgery, particularly in shoulders. It's very few of our shoulder patients are going off to get a surgical opinion, unless there's something obvious that we know that's not going to improve with injections, and our experience allows us to say, well, this probably won't get better with an injection. Whereas a frozen shoulder walks in, we know that that's the sort of gold standard treatment that we can offer at the moment. So again, it comes down to getting the right diagnosis for the right patient and getting them on the right treatment program.
If you're a patient listening to this and you've gone, yep, I've got a shoulder problem, I've been going through physio for X number of weeks and it's got a little bit better but nothing's really changed, is that the person that you'd go, you should probably get some kind of imaging, whether it be an ultrasound scan or something else? Like, what would your go-to be first?
So for a shoulder, which we see loads of, and is my particular interest, ultrasound is the imaging modality of choice for your as your first imaging modality. So if they're not improving, let's get some imaging. They could, and Reece, we've seen it all, they could have a tear, they could have calcification, they could have a raging bursitis, they could have lots of different things going on, and it may be that the diagnosis may change the management from a physio point of view, or it may be that you add in a guided injection or something else. But there's certainly, we have the 3 session sort of rule. If people aren't getting better in 3 sessions, then consider some imaging. Consider thinking, well, actually, maybe there's a little bit more to this. So somebody that's not getting better is going to be one of my main indicators of doing a diagnostic ultrasound scan.
Take home there,
which takes about 5 to 10 minutes. It's not
it really clears things up, doesn't it?
Yeah, it does.
But I guess the take home again there is just like we were having a bit of a chat about manual therapy before. It's not the be all and end all. It always has to play part of the bigger picture.
Yeah.
So the injection, while it's going to make you feel really good for 6 to 10 weeks, that is just part of the clinical pathway and part of the treatment. So we've seen them as physios. People go away, have their injection. Oh, my shoulder doesn't hurt anymore.
They come back 6 months later.
Don't do their exercises. Don't do that, and and then they end up having a second injection. And so the take home there is, just as ultrasound is just part of the clinical pathway, just as injection's part of the clinical pathway, manual therapy, everything plays its role, and that's where it's important to make sure that you sort of have that planning, isn't it, with your physio between patients to know where it's headed, and everything plays its little part.
But to have that all under one clinic, which is what we've got, is probably one of the sort of differentials, I think, in our clinic compared to other physiotherapy clinics, is we've got that one-stop clinic, that we can provide those different sort of elements to that patient depending on what's wrong with them.
Yeah, definitely.
Cool.
Any other questions?
No.
We haven't touched. I think we've touched on some pretty good stuff there.
We've got an idea of why and when we should be.
Yeah, the only thing I'd say is if there is any patients that are listening to this and they want to, myself and Dave, who run the clinic, spend a lot of the time speaking to patients. You know, is ultrasound relevant? Is steroid injection appropriate for them?
Yeah.
We'd much rather speak to somebody for 2 or 3 minutes and find out if this is appropriate before they book in.
Yes.
And it might be that it's more appropriate for them not to have a scan, actually see one of our rehab physios or go into Pilates, but we're more than happy to speak to people to find out whether or not it is appropriate for a scan or a guided injection. Yeah. So people see the right person at that first appointment, or not, as the case may be.
Yeah, and there's a bit of a conversation at the moment around steroid injections and things like that, which there always should be. You know, we should always be critical of things that we're doing. But I think the combination of the ultrasound is going to narrow the scope of who's having them to make sure it's the right intervention for them, not just willy-nilly sort of injecting whatever and hoping it works. Yeah. By having the imaging ultrasound scan in your case, it's narrowing the chances of that becoming successful for the people you're doing it with.
And a lot of this comes down to, you can read the research, you can read all of that and be up to date, but at the end of the day, a lot of this comes down to clinical experience and pattern recognition and seeing that type of problem before, and knowing what helped or what didn't help, and therefore probably finding the most appropriate treatment for that patient as quickly as possible, and not wasting anyone's time.
Perfect.
Beautiful. Thank you.
All right. Well, thanks for that, Chris. Very informative. Again, I've learned some things out of that, which is nice. Absolute pleasure. So yeah, for anyone out there listening, if you're keen on an ultrasound or you know nagging issue that you want looked at, certainly get in contact with Complete and we can get you booked in. So thank you. That concludes episode 2 of the Complete Health Podcast. For any further information or queries, please feel free to email into us at either Reece at complete-physio.co.uk or Helen at complete-pilates.co.uk. We're also on Instagram at Complete Health Podcast, all one word.
Keep an eye out over the next week for our third part in our chat with Chris about the treatment of Achilles tendon issues. And if you enjoyed this episode, you may also enjoy episode 1 that was released last week, where we delved into how Complete Physio and Pilates started and how they continue to grow.
Stay healthy and goodbye!